We look after 35 primary care sites in London, which cover a patient population of around 220,000 patients. Two of the key things that we like to concentrate on as an organisation is quality and training. 8 of our practices have the RCGP Quality Practice Award, and 3 of our practices have achieved CQC Outstanding. For the remaining practices that have been inspected, we've received a rating of good overall. 13 of our sites are postgraduate training sites for GP registrars and F2 doctors. And we now employ around 500 staff and provide around over 500,000 consultations per year, face-to-face or telephone. In terms of our footprint in London, these are the areas and CCGs we cover at the moment. We also look after extended hours access hubs, as well as walk-in centres and minor injuries units. So looking at some of the innovations that release capacity in primary care, we are aware of the NHS England GP Forward View document and the 10 high impact actions. So the 2 actions that we are talking about that we are kind of embracing for this innovation is productive workflows, number 5, and number 10, which is developing quality improvement expertise. And we think we do that with this product. EasyDoc is essentially a process and an innovation where admin staff are the first point of contact for all clinical related correspondence in the practice. Once that process has been embedded through training and audit, we find a reduction in GP admin time from about 1 hour in reading hospital letters to approximately 10 minutes a day. One of our salaried GPs in a practice in Peckham, Lauren Parry, this is what she had to say about it. If you can't read it at the back, I'll read it now. If you can introduce a process that improves the service you provide for your patients and reduce GP workload, why wouldn't you do it? We have GPs that have delivered and developed this training. So I personally have been involved about 3 years ago. I sat down with my staff, mapped out the process. Currently, this innovation is being delivered across 16 CCGs in London, and we're in discussion with 3 CCGs now in negotiation stage in terms of installing that product. What EasyDoc does is it gives the ability for you to see data and analyse your performance. That's really important for anyone here who's at federation level or CCG level, but also at practice level as well. And we believe this innovation is sustainable. We know that there is a churn in admin staff. You're looking probably over 10% turnover per year, and so we want to put in place an innovation that really is there once that admin member leaves and moves on, but that practice can continue delivering EasyDoc. In summary, we know it's a proven model across 220,000 patients in London. So looking at clinical governance and medical indemnity, that's really important for us as an organisation. The Medical Protection Society has been and visited us and conducted quite a deep analysis of the product itself, looking at the audit, looking at the clinical governance surrounding it, the protocols that underpin it, and then significant event analysis. And this is what one of the members of the Medical Protection Society said about the product. So moving on, with this innovation, we need to realise audit is a key part of this. The audit tool is really important. We provide that, and it's part of the product that we deliver to you, and it's central and easy to use. As I mentioned already, it measures performance and it provides business intelligence. We know that value for money is key with NHS funds, and so at CCG and Federation level, you can assess the impact of that across practices and also really do a deep dive into practices that are not embracing it or not taking part in it, and that helps to guide the innovation. It's worth noting that 3 of the practices where we've achieved CQC Outstanding have EasyDoc in place. I've personally been involved with CQC inspections, so an inspector's been around. I've talked about EasyDoc with him, and it's been viewed very positively and mentioned in reports in the CQC write-ups afterwards. I'll mention the safety audit. This is a screenshot. You won't be able to read it, but essentially what this is looking at is, in terms of the process, once it's in place, it's about the lead GP in that practice reviewing the letter that has not been sent to GPs and making a judgment and ensuring that that process is safe and it was done appropriately. Then there's another aspect to this, which is really looking at letters that should have been sent to the GPs, and then doing a deep dive into that, writing it up, significant event, and then feeding back to admin staff. So there's a continuous cycle of improvement. So in terms of benefits, there's several hours of GP time that's saved. Safety is important. It's much more streamlined now, it's standardized. So the letters are now going to 2 or 3 admin staff, depending on the size of the surgery, 2 or 3 admin staff. They're being dealt with in one standard way, as opposed to going to different GPs that might read the letter in a different way. One GP might say needs a routine appointment, another GP might say needs a telephone appointment, etc. So it's much more standard now. And then a kind of estimate of cost saving that we found is £11,000 of savings per 1,000 patients. So that isn't a real saving, obviously, but it's more the time that has been saved for GPs not reading those letters. So that could be GP time spent doing something else, for example, reading a complicated discharge summary and having more time to read that, or being able to speak to a frail elderly patient on the phone that's just recently been discharged. And finally, satisfaction. There's been a huge increase in clinical and admin staff satisfaction, and that's because admin staff are now no longer just being involved with picking up the phone or dealing with prescriptions. They're now empowered. They've been trained, they can read the letters, they know the patients better, and they're being involved in patient care. So looking at what we deliver in EaseDoc, it's a 5-step process. So the first thing is understanding current practice. We know it's very different across GP surgeries in one federation and across the country, I'm sure. So that's the first step, and we really want to baseline that for practices, and that will help. And that's a one-off exercise, and that helps practices to realise how much time is actually being spent by them and GPs reading hospital letters in the first place. Next step is co-designing the new working model. Now we realise it has to be different in each area. I mentioned to you we work across 16 CCGs. That's 16 different ways in which letters are sent to surgeries. So different specialties across different hospitals will have their own way of doing things. So we need to co-design this model specific for your area, wherever you are in the country. That's followed by training. That would be in practice. There's a mixture, so we kind of make it bespoke for the area where you are, face-to-face training, and then followed by an e-learning product, which will give the admin staff the ability to continue learning thereafter, but also achieve competency. Then that's followed by implementation. So there needs to be a process. That's the difficult process, because it's change, and in any team, change can be difficult, but that has to be sustained over a period of time. And finally, audit, as I mentioned several times already, we need to be in a place where we can at any time have reassurance for patients and staff alike that there is a continuous audit process going on where letters are being checked, or a snapshot of letters are being checked by GPs to ensure that those letters will safely workflow to admin staff. So in terms of implementation, just to touch upon this, we talked about GP-led workshops. So this would be GPs coming out to the areas where you are, liaising with local GP leads in their practices, as well as admin leads. There'd be some sessions of expert trainer and in-practice training, and then ongoing competency assessed online. So that would be in a similar method, kind of slightly similar to safeguarding, in the sense of going on an online tool, going through some form of assessment, followed by a certificate being awarded at the end of it. And finally, ongoing telephone, email, and web support. That is absolutely necessary. This is looking at impact, and this is my surgery where I work in Streatham, so Edith Cavell surgery. And when we installed this innovation there, I worked on it about 3 years ago, and this has been mirrored in several other practices, in all the practices that I've looked after. We see a consistent drop in the number of letters that are now going to clinicians. You're looking at a consistent improvement, and as I mentioned earlier, and we don't want to underestimate this, you're looking at retention of GPs, which is a problem we all face, and one part of this is the softer part, which is about retention and giving GPs the ability to have a effective work-life balance where they can not be so involved in admin work.
Here is based in Brighton. It's a non-for-profit social enterprise. It is a group of people who work together to try and make a difference to people. We provide NHS services. We provide about 700 clinics a year. We deliver prime contracts in MSK, also the front end of wellbeing services. We do diabetes in the community. We do dementia services, but we also have a GP practice, and we work with the 44 practices in Brighton. and we support them in frail, vulnerable people, and we also supported them in the Prime Minister's Challenge Fund. And I believe that this particular piece of work, which I'm going to tell you about, workflow optimisation, makes a difference to people because it enables people to be supported in their decisions about their care in a timely way with a person with accurate information whenever they need it. When I was a GP, we're looking at 40 work letters a day per GP, roughly. And I found that most people are doing this either in between surgeries or at weekends or in the evening. And actually to do this work properly, the data needs to be recorded properly, and then the actions need to be actioned well, as we all know, and we've all got different systems for doing that. And I find that when people are tired and they're pushed in work, they don't do the job properly. So we sat down with an administrator in our organisation called Jane Williams, and she had never done work in a practice before. So I sat with her over a period of 2 to 3 months, and we went through what do I do when I read clinical correspondence, and we worked through it bit by bit. And we discovered that actually she quickly became much more effective and efficient, because this was her focus and purpose of work, and she was able to read code and select things very very accurately, and that she was connecting to patients and able to phone them up and move them on in their journey and make sure they got followed up in the way in which had been requested in those letters. The effect of that is that for about 8,000 patients, a whole-time equivalent of Jane was able to provide this for about 8,000 patients worth of clinical correspondence. Now what we discovered was that when we spread that out to other practices, we did another 10 practices, we discovered that we had exactly the same effect in those practices as well. So where are we now? So we've now trained 300 practices. Up to 80% of the clinical correspondence is still being completed by a competent workflow administrator. We discovered some other things as well. We discovered that GPs aren't trained in recoding, generally. We've also discovered that stewardship of the patient is better, because we have better processes for DNAs. We actually do make sure we contact people when they get those DNA letters and make sure that they don't get lost to follow up. We've also discovered that we can put the blood tests in, we can do the blood monitoring, and we also put appointments in. They book into our appointment system, and we're connecting the individual, the workflow administrator, to the patient. Again, as I said, 40 minutes per day was in our EPIC pilot, and 30 minutes per day in the further 50 that we did. So we're also discovering that GP capacity is being freed up. People are going home at 6:30 rather than at 9. And when we have a GP that says, oh no, I need to see all the clinical correspondence, we say, fine, well, you carry on doing that. Well, the other 3 GPs will do this bit of work. And they quickly see their colleagues going home, and they quickly understand that actually maybe this is something that really makes a difference in a practice. So when we work with people, we are going to work with them make a commitment over a 2-year period, because we believe that we need to achieve the impact that you've paid us to do. So we know it takes time. So this is someone this is an administrator just learning over time, over month by month by month, and they become more and more percentage of letters that they can read and close off. It grows over time. And that takes time, and we know it takes time because different letters are difficult to read. So we've got A&E letters, orthopaedic letters, discharge summaries, mental health records. We know which volume comes with percentage of mental health letters that come, and the likelihood of them being able to be closed off by that person. So we train people sequentially in the easier letters to read, and we then get down to the more nuanced stuff around endocrinology or ophthalmology, when things are actually quite hard and there's, the clinicians are using difficult words and medications aren't clear, then actually we train them further down. So once you have got someone who's competent, you also want to know on an ongoing basis actually what's happening. So you get a dashboard, you get the data fed back, it comes back to you as a practice. But you get, for example, the number of letters that have been closed off that day. You can see over time on that graph on the left, that shows that on average 10 to 15 days that these letters are sitting in people's workflow system. over a period of time, they're down to like 4 days of getting closed off. So as a manager, you've got an idea of what someone's actually doing in your practice. So the importance of a GP championing governance and safety for patients. We teach you not just about how to do the training, etc., but we teach you about how to implement change sustainably within your practice. And the key part of that is leadership, and it's about GP leadership and GP champion work. And so we need to know that that GP champion is going to bring on board the entire practice, and they're going to know that they're doing something different from the day that it's working. But we also have other safety around medication protocols, because that's absolutely key. And then we have quite a robust audit and feedback tool, a significant event and incident reporting system, and all of this has been overviewed by the MPS and the MDU and the MPPDUS, and they've all verified that this does not create greater risk in the system. It's a 4-day training program. You get all kinds of stuff. You get manuals, protocols, an e-learning tool. You get support in terms of WebEx kind of support for the GP champions. We learn together how to learn. So really we've turned it from training to facilitation, because different people in the room have got different experience. Our longer term relationship is more about making sure that you get impact. So we recognise that when people get trained, they don't always implement it in their practice, but what we're paying for here is implementation in a practice, not a training program. We recognise this is not a one-way process. It's very bespoke. Different federations want different things, different networks want different things, different practices want different things. So we make sure that we listen and we change the system as that happens. And then we share that learning across that network on a wider basis. And we're constantly looking for ways of improving what we're doing. So my last slide is that you know that the money is there. NHS England have provided this money. It is, in inverted commas, ring-fenced. We cost at 40p per patient over a 2-year period. We make it very clear there will be a cost pressure for your GP, for your administrative staff depending on how much you currently already do. We are looking at how we create train-the-trainer models so that you have sustainability within your network. Because once you're trained, because we know people leave and move on, we don't want those skills disappearing, and we will support you with creating more primary care networks.
EasyDoc has been put into a practice with 2,500 patients, and it's also in a practice with 14,000 patients. So it isn't a problem in terms of small size. Obviously, there are different things happening in those practices. So in a small 2,500, there might only be 3 admin staff on a daily basis. So it's more about training 2 of those at least, rather than having 1, because if one's on leave, then it piles up again. So that's one aspect. But in a larger practice, it's about training more staff. But also with a larger practice, you can have an option of centralising functions, so having more than one practice. So we've done that as well. So having more, someone sitting in one practice and taking on 3 other surgeries and doing it in one site.
The next problem to solve is actually within a network of someone who's got 3,000 patients and someone who's got 17,000 patients, and you've got 4 or 5 other practices, how do you start helping them as practices and as a team, looking at how they cross-cover each other if there's illness or someone leaves, and create sustainability within it. So I think it doesn't get away from if you're a 3,000 patient practice, it's risky when staff leave and it causes big impact. We teach you on your systems. There's no extra system that you're going to have to use to make this happen.
So you can link
EMIS, System 1, Document, even Vision. Yeah.
So just to add to that, for the audit tool I demonstrated, it hasn't got patient data on it. It's not incorporated in. That's more for impact. It's about numbers and data and the number of letters coming through. And I think it's the same for Jonathan.
This isn't an additional piece of system that you need to implement. There's no interoperability issues. There is no compliance issues.
So normally we'd come out and we'd have a conversation with a large number of your practice and team, yeah, and actually I don't normally do this bit. It's done by our team who are doing the presentations, and so there'll be Paul and maybe Jay, but also actually Jane goes out, and so do our trainers, and they talk about that peer-to-peer kind of conversation about actually this opportunity connects you to your work in a different way. Because before you were scanning, sitting in a room, seeing a pile of information coming up, getting a lot of general chat when you get behind it, and then putting in data. But now you're connecting to the patient journey, and it changes that.
Of the letters that remain, we've employed about 25 pharmacists over the last 12 months. So a lot of our letters that are remaining now go to the pharmacists anyway, but the remaining ones, literally you're talking about 3 or 4 letters, it will be a complicated elderly patient with a discharge summary, and it will be about the GP being involved in phoning that patient and actually giving that personal advice. The AUA is there, and that can be an admin person following up, but it's actually, hello, I'm Dr. Qureshi, I'm ringing you about your discharge. How did it go? Can I help you with this? And that gives the personal touch. That hasn't been measured yet, but let's be honest, in reality, if we had 40 letters, we probably wouldn't do that at the end of an evening surgery. So that's a major aspect.
To add that, with the same experience, got 11 pharmacists, and the experience is that because you were using unfilled GP capacity with locums, and you're then actually able to put a different workforce with less cost into that particular thing, you start to realise those savings. When you start to do that over a network or a federation, then that starts to be significant and way outperforms the cost of this training. Well, we come to your local area. Obviously, if you were around Brighton, you would come to we do it in offices, but we basically saw part of our team, they source the site, they source the infrastructure, they check that it all works, and then we come and do that wherever you are.
So
within
for the administrator would be on site?
Within a geographical location that's reachable by everyone.
Okay.
Yeah.
So our model is we have a workshop, which is a face-to-face workshop. It would be in a room quite similar to this in that you'd have GP leads from practices as well as admin leads, whether that's the manager or someone senior within the practice team. That's a workshop which is GP-led. So one of our GP directors, Dr. Qureshi is one of 6 of our GP directors, would lead that workshop. That's around orientation to EasyDoc, what this is going to mean as part of the change management within your practices, and a bit of a cultural training program as well as how does the process work getting to end. A lot of that's prefixed by some things which they'll do before they turn up as well. And then in-practice training is delivered by our expert trainers, so they would actually go into the practices. In our experience, both in our practices and elsewhere in other CCGs, we found that 3 sessions are sufficient, but that's not 3 sessions and it's up, it's then supported as well. And I think equally for both organisations, what we both are really keen to see is a sustained change. So what we've noticed is that this is sufficient to see a sustained change, but then there is communication thereafter if more support is required. But I guess a key aspect of what we found is extra helpful is the online learning. So a lot of what we cover, and for example, standardization around read code training, how to identify the letters which should go to a GP and shouldn't, that we've modularized into e-learning, which is then competency assessed.
This next year in April, the money will come out £10 million equally across all CCGs, and it will be advised, I'm informed, I had a conversation this morning, that this is what it should be used for. And then it will be 10 million, 10 million, 10 million for the next 4 years.
That's coming in April?
It's meant to be released in sometime in April, but it will be, as NHS England's other priorities are, make that happen. The money will be there, it's there.
Yeah.